Hi everyone, my name's Natalie. I'm the oncology pharmacy resident here at Monument Health. And for my clinical pearl this month, I'm going to be talking about a therapy that we recently treated a patient with acute myeloid leukemia. This medication is Gemtuzumab Ozogamicin, and this was a new therapy that really had not studied or researched, so I wanted to look more into this medication. So my objectives are to talk about the mechanism and pharmacology with Gemtuzumab, and then talk about several of the clinical trials and some of the interesting and differing findings that the trials have found with Gemtuzumab. And then I'll finish by talking about the current guideline recommendations for use of Gemtuzumab for patients with AML. So first wanted to just provide a brief overview in terms of the mechanism and pharmacokinetics of Gemtuzumab. So it is, as a mechanism, it is one of our antibody drug conjugates. So Gemtuzumab is our anti-CD33 targeted monoclonal antibody, and then Ozogamicin is our cytotoxic moiety. It's actually a very potent anti-tumor antibiotic that causes double-stranded DNA breaks and cell death. For the CD33 target, so this is highly expressed on a majority of AML blast cells, so up to 90% of adult patients with AML will have CD33 expression. We do not see CD33 commonly, though, on our normal myeloid cells, our normal hematopoietic cells. It was interesting for me to delve into the approval history of Gemtuzumab. It definitely has kind of some notable findings. So it was actually approved way back in 2000 on an accelerated approval for older adult patients over the age of 60 who were not candidates for standard cytotoxic induction therapy. And the dosing with that initial approval was 9 milligrams per meter squared on day 1 and day 15 given with induction chemotherapy. Following this accelerated approval, though, there were some post-marketing safety concerns that were reported, one being that patients rarely experienced this significant respiratory distress syndrome and pulmonary edema within 24 hours of receiving Gemtuzumab. And again, it was rare, reported in 8 patients, but a very high mortality rate, so 5 patients were deceased. And then there was also concern for hepatotoxicity, and particularly related to patients going on to stem cell transplant. So they did see an increased risk for veno-occlusive disease or hepatic sinusoidal obstructive syndrome, or SOS. So they showed that 64% of patients who had received Gemtuzumab developed VOD or SOS, in comparison to only 8% that had not received Gemtuzumab. And then, as the accelerated approval required, there was the release of this phase 3 confirmatory trial, which was the SWOG SO106 trial that I'll be talking more about in detail. But this trial actually did not show a survival benefit with Gemtuzumab in combination with induction chemotherapy versus chemotherapy alone for patients with de novo AML. And you can see they did administer a dose reduction of daunorubicin of 45 milligrams per meter squared, given with or without Gemtuzumab, 6 milligrams per meter squared. And so based on the interim analysis for this trial, showing no significant difference in response between groups, this trial was actually closed early. And in June of 2010, Pfizer voluntarily withdrew Gemtuzumab from the market. However, there were follow-up studies that were done after this withdrawal from the market and was based on a different dosing of Gemtuzumab, so looking at a lower dose of the 3 milligrams per meter squared instead of the 6 or 9, and then using a fractionated dosing schedule. And this was based on studies that had shown that there is a high re-expression of CD33 proteins on the cell surface of those blast cells within about 72 hours after Gemtuzumab administration. So by administering, lower doses more frequently, thought to be better targeting of those CD33 receptors. We also saw that this lower dose was associated with a lower risk for toxicity, particularly hepatotoxicity. So based on these conflicting trials and dosing, they did undergo a meta-analysis of all phase 3 trials, and I'll be talking more about this meta-analysis as well. But looking at Gemtuzumab in combination with induction chemotherapy, they included 5 phase 3 trials in this study, and they did show that the addition of gemtuzumab decreased the risk for relapse as well as improving 5-year overall survival. They did show particularly that the highest benefit was among patients with favorable risk cytogenetics, but they did not show that any specific chemotherapy backbone was associated with better results with gemtuzumab. But based on the results of this meta-analysis in 2017, the FDA did reapprove gemtuzumab for both newly diagnosed adult and pediatric patients or patients with relapsed or refractory disease with CD33 positive AML. In terms of pharmacokinetic data, so unfortunately we actually do not have any pharmacokinetic data available for the fractionated dosing. We really only have it for that unfractionated 9 milligrams per meter squared. But they did note in pharmacokinetic studies that doses greater than or equal to 2 milligrams per meter squared, there was saturation of all of those CD33 binding sites. So again, giving some merit to the use of the fractionated dosing. With the standard unfractionated dosing, though, we did see that Cmax increased from the first to the second dose. In terms of distribution, the cytotoxic Ozogamicin is highly bound to plasma proteins, and then the half-life increases from 62 hours to approximately 90 hours with the second dose. Gemtuzumab is also extensively metabolized, but primarily through non-enzymatic means. In terms of dosing and administration, so currently we do have the indication for that fractionated dosing for patients that are newly diagnosed with de novo AML in combination with induction chemotherapy. So for induction, it's 3 milligrams per meter squared given for 3 doses every 3 days, and then for consolidation, 3 milligrams per meter squared as well on day 1 only. For those with newly diagnosed AML who are receiving it monotherapy, there is a recommended 6 milligrams per meter squared induction dose on day 1, and then 3 milligrams per meter squared on day 8, followed by a continuation of 2 milligrams per meter squared on day 1 monthly for up to 8 courses or for 8 cycles. And it's important to note that this is only for patients without evidence of disease progression following induction therapy. And then for those with relapsed or refractory disease, gemtuzumab can also be given as monotherapy, and that is again recommended that 3 milligrams per meter squared every 3 days for 3 doses. So for the specifics of dosing and administration, they do recommend cytoreduction for patients with a white count above 30,000 prior to administration. There are also pre-medications required to prevent any sort of infusion reaction. It's given over 2 hours, and there is no renal dosing, although it has not been studied in a creatinine clearance less than 30. For hepatic dosing, for mild impairment, there's no dose adjustment, but it has not been studied in moderate or severe hepatic impairment. And then for patients who develop any sort of an infusion reaction, it is recommended to monitor patients for at least an hour after the infusion, and then they can resume the infusion at half the rate if their symptoms recover. In terms of dosing adjustments for hematologic toxicity, we do see risk for thrombocytopenia, and so if that platelet count does not recover to greater than or equal to 100,000 within 14 days of their start date for consolidation, it's recommended to discontinue, as well as if grade 4 neutropenia does not recover within 14 days of planned consolidation, also recommended to discontinue therapy. For infusion reactions, as I mentioned, the infusion can be resumed at half the rate if those symptoms recover. And then for bleeding or hemorrhage, recommended to either delay or discontinue therapy. And for any concern for hepatotoxicity, such as VOD or SOS, it's recommended to discontinue therapy. As I mentioned, the fractionated dosing does carry a lower risk for hepatotoxicity, but it still does carry that black box warning for hepatotoxicity. Typically, the median onset is about 9 days from the dose, and as I mentioned, does have that dose-dependent risk. But for those with baseline hepatic impairment, been shown to have almost a 3 times increased risk for VOD and SOS if they go on to transplant. And so it is recommended that there's a spacing of at least 2 months between the last dose of their Gemtuzumab and any planned transplant. And NCCN specifically recommends 60 to 90 days of spacing between Gemtuzumab and any planned transplant. For other safety considerations, there is the risk for infusion reaction, so pre-medication is required as well as monitoring for an hour after the infusion. And then risk for hemorrhage, particularly the risk for prolonged thrombocytopenia. So they did show that that platelet count did not recover above 50,000 in about 19% of patients in clinical trials, and then rates of grade 3 or 4 thrombocytopenia have been seen in about 20% of patients. Also risk for QT prolongation, so electrolyte monitoring and EKG monitoring is recommended at baseline if patients are at risk for that. And then tumor lysis syndrome due to just general risk with leukemia, so recommended standard uric acid lowering therapy and an IV hydration. Next, I wanted to jump into the clinical trials for Gemtuzumab and kind of talk about some of the interesting and conflicting data that the clinical trials have shown. So the first trial I wanted to start out with is this Alpha 0701. Alpha is the Acute Leukemia French Association, and this study was published in Lancet in 2012. This study was looking at if the addition of low-dose fractionated Gemtuzumab, so that 3 milligrams per meter squared, with the addition of standard first-line chemotherapy, would improve outcomes in patients with AML. And again, using that fractionated dosing due to the thought that there's this rapid re-expression of the CD33 on the surface of those AML blast cells. This was a phase 3 randomized study, so patients were randomized 1-to-1 to the standard 3+7 induction with daunorubicin, 60 milligrams per meter squared, cytarabine, 200 milligrams per meter squared, and then Gemtuzumab, 3 milligrams per meter squared. Patients had a bone marrow biopsy done on day 15, and if that still showed higher than 10% leukemic blast cells, patients underwent a second induction chemotherapy course with daunorubicin and cytarabine, and then they received colony-stimulating factor daily until their counts recovered. This was an open-label, multi-center trial. Included adult patients, older adult patients, age 50 to 70 with a confirmed AML diagnosis that had not received prior treatment and had normal cardiac function. They did exclude patients that had a prior history of preceding myeloproliferative or myelodysplastic syndrome, as well as those that had received prior chemo or radiation, or had uncontrolled infection or CNS involvement of their AML, as well as those with renal or hepatic dysfunction. Their primary outcome was event-free survival, and then for secondary outcomes, they looked at relapse-free survival as well as overall survival and safety. And they did look at outcomes that measured during treatment as well as day 45 following treatment completion. For their statistical methods, they looked at the intent to treat population for their analysis. They estimated that they would need 140 patients or 184 events total to detect a difference in 2-year event-free survival of 25% in the control compared to 40% in the experimental group with Gemtuzumab. They used a Fisher's exact test and a Mann-Whitney test, and then a standard two-sided significance level of 0.05 for their p-value. For patient demographics here, you can see median age was just over 60. They randomized 139 patients to each group, so a total of 278 patients in the study. Majority of patients did have an ECOG of 0 or 1. And then I wanted to point out here that majority of patients in both groups did have that intermediate cytogenetic risk. For results, they did determine that complete remission was achieved in a total of 73% of patients in this study, and an additional 5% of patients had a complete remission with incomplete platelet recovery. When they looked at the differences between the control versus the experimental group, those that achieved complete remission were 75% in the control in comparison to 81% in the experimental group. So that was a p-value of 0.25 between the groups, so no significant difference in achieving complete remission between groups. And then in terms of repeat induction, they did show slightly higher, 92% in the control group compared to 87% in the experimental group. In terms of the results looking at event-free survival and overall survival, though, they did show that the addition of Gemtuzumab did significantly improve both event-free survival as well as overall survival. So you can see mortality rate of 52% in the control group in comparison to 42% in the Gemtuzumab group. So that was a p-value of 0.0368. And then looking at the event-free survival differences and the forest plot here between groups. So you can see certainly a trend towards patients with favorable or intermediate cytogenetics really favoring that addition of Gemtuzumab in comparison to those with unfavorable cytogenetics, showing improved event-free survival. And then looking at overall, looking at their differences in overall survival here, again, we see that trend towards those with favorable or intermediate cytogenetics being favored to have the addition of Gemtuzumab. For our Kaplan-Meier curves here, so on the top we have event-free survival, and then on the bottom we have our overall survival results. So again, significant in both groups for showing improvements with the addition of Gemtuzumab in comparison to standard induction chemotherapy. For safety events, as we have already discussed, there is that risk for prolonged thrombocytopenia that's been observed with Gemtuzumab, and they did show that that was significantly different between groups. So a total of 4 patients, or 3% in the control group, had non-recovery of their platelets in comparison to 16% in the experimental group, and that was defined as platelets unable to be above 50,000 or attaining platelets above 50,000 by day 45. So that was a significant finding. They did show that there was a higher incidence of grade 3 and grade 4 hemorrhage in the experimental group with Gemtuzumab, but that did not reach statistical significance. So again, looking at that difference in thrombocytopenia, which they defined as platelets less than 50,000, and a significant difference between groups there. And then persistent thrombocytopenia, again, looking at that day 45 marker and looking at that difference between groups after the first consolidation as well as the second consolidation. For looking at actual adverse events, so they did show a higher rate of total grade 3 and grade 4 events with Gemtuzumab in addition to standard induction chemotherapy. But did want to point out, particularly with that concern for hepatotoxicity, so risk for grade 3 or 4 liver toxicity was observed in 6% compared to 13% with Gemtuzumab. But that was not a significant difference between groups, p-value of 0.1. And they did note that predominantly the liver dysfunction did occur in the context of sepsis in both groups, so not specifically related to VOD or SOS in this study. So in conclusion, this alpha study did determine that the addition of Gemtuzumab to standard induction chemotherapy improved survival outcomes with older adults with AML. So they recommended that it should be considered as part of a first-line therapy regimen. Also that the fractionated dosing allowed for more effective drug delivery as well as lowering the risk for toxicity. They did show that adverse events were more frequent in the Gemtuzumab group, particularly thrombocytopenia and delayed platelet recovery. And they did show similar rates of mortality during induction and treatment between the groups. Next, I want to move on to the phase 3 confirmatory study, the SWOG trial that I mentioned already, looking at Gemtuzumab during induction and consolidation for younger adult patients with AML. So this study aimed to determine the potential benefit of adding Gemtuzumab to standard induction and consolidation therapy for adult patients with AML. This was a phase 3 randomized trial, and this, as we mentioned, patients received either standard induction with daunorubicin 60 milligrams per meter squared and cytarabine 100 milligrams per meter squared, or received daunorubicin 45 milligrams per meter squared with standard cytarabine and Gemtuzumab given at 6 milligrams per meter squared. The lower dose of daunorubicin was noted in this study due to phase 1 and phase 2 studies that had shown that this was really the maximal tolerated daunorubicin dose when given in combination with Gemtuzumab. And then for consolidation, patients either went on to observation with no therapy, or they could receive Gemtuzumab 5 milligrams per meter squared for an additional 3 cycles. They included younger adult patients, so age 18 to 60, with an ECOG of 0 to 3 and had adequate organ function. They excluded patients with a history of APL, as well as those with cardiac dysfunction, known hepatitis, or those that had a preceding hematologic malignancy before their AML diagnosis, or those that had received prior chemotherapy. Their primary outcome was to determine whether complete response rate was higher among those who received Gemtuzumab in combination with the standard induction regimen, as well as to look at that post-consolidation disease-free survival and differences between Gemtuzumab versus standard induction chemotherapy. For their statistical methods, they estimated that 342 patients would be needed to determine a difference in disease-free survival during that post-consolidation therapy, and that was with a 90% power with a one-sided alpha of 2.5%, assuming a hazard ratio of 0.67 for improved disease-free survival with the combination of Gemtuzumab and standard induction chemotherapy. They also assumed that 50% of all patients enrolled in the study would enter that post-consolidation randomization phase. So they would essentially need a total of 684 patients total to have a 90% power to assume a complete response rate of 81% with combination compared to 70% with daunorubicin and cytarabine alone. So for patient demographics here, you can see majority of patients were over the age of 35, and just over half of them were male, and then looking at their baseline laboratory values. In terms of their cytogenetic risk factors, again, we do see that majority of patients, as we saw in the ALPHA trial, majority of patients do fall into that favorable or intermediate cytogenetic risk category. And they did randomize a total of 637 patients in this trial. For efficacy, in terms of differences between groups, looking at that complete response rate, so you can see that there was not a significant difference between groups, 69% with the combination in comparison to 70% with induction chemotherapy alone, so p-value of 0.59. And then in patients with resistant disease, they actually showed a lower response rate, so 15% in comparison to 20% with standard induction chemotherapy alone. So again, no significant difference between groups in terms of overall survival or relapse-free survival. Looking at their overall survival, so they did note in this study that there was a particularly higher rate of early mortality with the Gemtuzumab in addition to standard induction therapy. So they noted that 17 patients who received that Gemtuzumab with induction died within the first 30 days compared to only 4 patients who received standard induction chemotherapy. So they determined that may have been a driver, particularly of their overall survival results. But again, that trend towards prolonged overall survival with standard induction therapy may have been due to that higher early mortality rate seen with Gemtuzumab. And then next, looking at that relapse-free survival, again, really no significant difference between groups with the addition of Gemtuzumab. So looking at 27 versus 32 months for relapse-free survival. For that post-consolidation therapy, so a total of 169 patients who achieved complete remission were then eligible for post-consolidation therapy, and 85 of them were randomized to receive those 3 additional cycles of Gemtuzumab. And they did not show that Gemtuzumab significantly improved disease-free survival in comparison to those who just received observation alone. So hazard ratio of 1.48 with a p-value of 0.97. For safety events, they did show that there was a higher risk for fatal toxicity among patients who received the combination of Gemtuzumab and induction chemotherapy compared to chemotherapy alone. So you can see fatal toxicity occurred in 16 patients, 5%, in comparison to 4 patients or 1% who received standard induction chemotherapy. However, they did not note that this higher toxicity was related to increased risk for hepatic dysfunction, particularly VOD or SOS. So again, risk for liver dysfunction occurred in 1 patient receiving the Gemtuzumab compared to none with the standard induction chemotherapy. And then any grade occurred in 21% of the Gemtuzumab compared to 12% with induction chemotherapy alone. So based on the findings of this study, the hypothesis was that the complete response rate would be improved by 12% with Gemtuzumab, and so clearly that is not what was shown in this study. So at that planned interim analysis, the study was actually halted early due to not showing a significant improvement with the addition of Gemtuzumab. So this SWOG trial failed to demonstrate that improvement in complete response, relapse-free survival, or overall survival with Gemtuzumab added to standard induction therapy. They did note as well, as we talked about, that higher risk for fatal induction toxicity with Gemtuzumab, so 5.5% compared to 1.4% with standard induction chemotherapy alone. And they did note that this, in general, is a low rate of toxicity with standard induction chemotherapy. So typically, actually more of 5% risk for toxicity is seen with standard induction chemotherapy. So they did note that it was abnormally low in this trial. They did note as well, though, that there was a low rate overall of hepatic dysfunction contributing to any fatal toxicity. They did note that cytogenetic risk did impact the effect of Gemtuzumab, so there was an improved overall survival with patients with favorable risk karyotypes, so 79% versus 51% 5-year overall survival. So that was a significant finding. And then also decreased risk for relapse at that median follow-up of 30 months with the addition of Gemtuzumab. So last, I wanted to talk about kind of the summary of both of these trials, looking at that meta-analysis that I talked about that really helped to lead to the reapproval of Gemtuzumab. So this was a meta-analysis published in Lancet Oncology in 2014. And this meta-analysis, again, really was really trying to help solve some of the conflicting data related to Gemtuzumab. So, why do we see that it has a higher risk for early mortality, but then, may provide an overall benefit in terms of decreasing relapse? Also looking at the variable daunorubicin dosing that was utilized in the trials with Gemtuzumab, and then also the fractionated Gemtuzumab dosing being, something kind of new in comparison to that original approval. So really trying to kind of solve all of those questions. So looking at efficacy of addition of Gemtuzumab to induction chemotherapy for adult patients with AML. So as I mentioned, this was a meta-analysis of randomized trials with a publication of 2013 or later. So they administered Gemtuzumab to adult patients with newly diagnosed AML, either de novo or secondary AML, randomized to Gemtuzumab with induction chemotherapy or induction chemotherapy alone. And I did want to point out that for this meta-analysis, the researchers did actually retrieve individual patient data from each research investigator, so really combed through the data independently for this meta-analysis. For inclusion, so they did require that Gemtuzumab be given concurrently with induction chemotherapy, and then looking at adult patients with newly diagnosed AML, either de novo, secondary, or related to high-risk MDS, and excluded any patients that received any reduced intensity induction regimens. Their primary outcome was overall survival. For secondary outcomes, they looked at complete remission as well as 30-day mortality, relapse-free survival, relapse risk, as well as survival from complete remission, or those that went on to stem cell transplant and survival outcomes there. For their statistical methods, they used a meta-analytic fixed effects method. And so looking at comparisons within each trial for observed versus expected events and looking at that variance. And then they did look at stratification if there was significant heterogeneity. And then using survival curves, again, based on this early breast cancer trialist collaborative group method for that observed minus expected within each trial. So these are the 5 trials that they included. And again, we've already covered the SWOG trial that did not show great benefit with Gemtuzumab, as well as the French Alpha study. So again, a total of 5 randomized trials were included in this meta-analysis. For patient demographics, median age was 58, and just over half of them were male. Majority of them, 88%, did have de novo AML. And then for cytogenetic results, they did show 29% had the NPM1 mutation associated with favorable risk, as well as 20% with the FLT3 mutation. There was a median follow-up of 60.8 months in this meta-analysis, and they did show that remission occurred in 78% of patients, with a median overall survival of 22.5 months. They did show that 785 patients did go on to receive stem cell transplant, with majority, 58%, being during that first course of chemotherapy. And they did note that there was no harmful effect for those patients that went on to receive stem cell transplant who had received prior chemotherapy, prior Gemtuzumab. So particularly looking at that risk for VOD or SOS for patients receiving transplant. In terms of efficacy, they did show that the addition of Gemtuzumab to standard induction chemotherapy significantly reduced the risk for relapse, so an odds ratio of 0.84, which was significant, as well as significantly improved relapse-free survival for Gemtuzumab, odds ratio of 0.87. And so estimated absolute improvement in that overall survival rate at 6 years was about 3.7% was their estimate with the addition of Gemtuzumab. And they didn't see any significant heterogeneity based on dosing regimen within the 5 different trials. In terms of risk for relapse, looking at some of the different dosing, though, looking at that single dose versus fractionated dosing. So we do see that there is a trend, particularly with the alpha trial that we talked about using that fractionated dosing, a trend towards favoring Gemtuzumab with the fractionated dosing. And then looking at mortality rate after achieving complete remission, again, we see that benefit with the fractionated dosing that we saw with the alpha trial, looking at favoring Gemtuzumab. And then in terms of relapse-free survival, again, trend towards fractionated dosing and favoring Gemtuzumab for relapse-free survival. For survival after achieving remission, similarly as well, favoring that fractionated dosing. And then this was interesting, looking at the cytogenetic risk factors and then looking at overall survival. So on the left-hand side, we have favorable cytogenetic risk, and so you can definitely see a big difference between groups favoring the addition of Gemtuzumab. In the middle graph, we have those with intermediate cytogenetics. So again, significantly favoring the addition of Gemtuzumab. But then with the last column, we do have patients with adverse cytogenetic profile, and that no significant difference with the addition of Gemtuzumab. They did exclude patients that had less than 20 metaphases available for cytogenetic testing for this meta-analysis. So then last, looking at overall survival differences between Gemtuzumab versus standard induction chemotherapy alone. So again, that trend towards favoring the fractionated dosing, in particular with the alpha trial. For safety, they did show a significant increase in 30-day mortality, as we talked about, that increased risk for early mortality with Gemtuzumab, but there was a high level of heterogeneity between studies, particularly, as we've already talked about, with that SWOG phase 3 confirmatory trial having a remarkably low rate of mortality with standard induction chemotherapy. So they actually, when they excluded the data from that SWOG trial, they showed that 30-day mortality was not significantly different between the studies. So odds ratio of 1.13, p-value of 0.4. They did show, though, that there was an increased risk for mortality among those who received the higher dose of Gemtuzumab, so 6 milligrams per meter squared versus 3 milligrams per meter squared. As well as among that subset of patients that went on to receive transplant, the 100-day mortality was lower if they had received that lower fractionated dose of Gemtuzumab. So for conclusions with this meta-analysis, they did determine that adding Gemtuzumab to standard induction chemotherapy improved overall survival for AML patients. And they also, again, a strength was that they really sifted through the individual data for each of those trials for inclusion in this meta-analysis. They did show that this improved overall survival was not associated with increased risk for early mortality, particularly with the lower dose of Gemtuzumab, and also highlighting that SWOG trial had that abnormally low rate of mortality associated with standard induction chemotherapy in that control group. But they do think that the overall survival benefit is mainly driven by that decreased risk for relapse, for late relapse with Gemtuzumab. And then also particularly for patients with favorable or intermediate risk cytogenetics. So based on this meta-analysis, then the authors recommended that Gemtuzumab really be, a viable drug option for that CD33 target, and particularly with the ability to improve overall survival, and that there should be consideration for reviewing Gemtuzumab's regulatory status and really leading to its reapproval and current indication for therapy. So that brings me to looking at our favorite guidelines and looking at really the role in therapy for Gemtuzumab currently. So currently for patients, adult patients that are eligible for induction chemotherapy, for those with favorable risk cytogenetics, so that does include NPM mutated or FLT3 wild type, they do recommend that Gemtuzumab be given with the standard 7+3 or 3+7. I've seen it both ways, given with Gemtuzumab for those patients in particular. And then they also recommend for patients that are not eligible for high-intensity therapy, so those that are looking at more of our older adult population, they do recommend Gemtuzumab if it's a CD33 positive AML and they do not have other actionable mutations, that Gemtuzumab be given as monotherapy. That is a category 2B recommendation. And then last, just wanted to talk about the dosing of Gemtuzumab per the NCCN guidelines. So they do recommend currently daunorubicin 60 milligrams per meter squared when given in combination with Gemtuzumab using that 3 milligrams per meter squared fractionated dosing on days 1, 4, and 7. So moving on to my summary here. So Gemtuzumab is an antibody drug conjugate. We have that CD33 targeted monoclonal antibody given with that cytotoxic moiety, the anti-tumor antibiotic, the Ozogamicin, currently approved for de novo or relapsed refractory AML. We see that CD33 is a viable drug target due to its high expression on a majority of AML blast cells and then low expression on our normal myeloid cells. The fractionated dosing that is kind of our new standard with Gemtuzumab in comparison to its original approval has been shown to be beneficial due to that rapid re-expression in CD33 on the surface of those blast cells shortly after drug administration. The lower dosing of Gemtuzumab is also associated with a lower risk for hepatotoxicity, but it does still carry the black box warning for VOD and SOS. So current NCCN guidelines recommend that it not be administered within 60 to 90 days of any planned stem cell transplant for patients with AML. And then looking at our 3 different trials that we looked at in this presentation. So the alpha was our initial trial that showed a positive benefit with Gemtuzumab added to standard induction chemotherapy for older adults with newly diagnosed AML. We did show that it improved survival outcomes, but was associated with increased risk for prolonged thrombocytopenia, but not significantly increased risk for hemorrhage. And then we had the phase 3 confirmatory SWOG trial looking at Gemtuzumab given with standard induction chemotherapy. They did use a dose reduction of daunorubicin in combination with Gemtuzumab. And unfortunately, this trial was stopped early due to lack of benefit with Gemtuzumab, as well as that increased early 30-day mortality. But again, this trial also showed a remarkably low rate of mortality with their standard induction chemotherapy. So then with these conflicting trials, a meta-analysis was performed comprising 5 randomized clinical trials. They did obtain individual trial data from each research investigator for inclusion in the meta-analysis, and they did show that Gemtuzumab in combination with induction therapy improved overall survival and really highlighted that decreased risk for relapse associated with Gemtuzumab. And they did not see an increased risk for early 30-day mortality when they excluded the results of the SWOG trial in this meta-analysis. So thank you so much for listening to my clinical Pearl on Gemtuzumab. And here are my references.